recognizes the ranking member for opening statement. I yield to the ranking member for an opening statement. I yield back.
Good morning, Madam Chair.
Thank you, Madam Chairman.
Distinguished gentlelady from California, Mary Bono.
Gentlelady is recognized.
Chair now recognizes
the lady from California is recognized.
I'm pleased to introduce Congresswoman Mary Bono, former U.S. Representative for California's Inland Empire and Desert Region from 1998 to 2013.
Mr. Speaker, I yield myself such time as I may consume.
Gentlelady is recognized.
Hello and welcome to Sagely Speaking. I am Mary Bono and I'm your host. I have such a fabulous guest today. Dr. Sally Satel is a practicing psychiatrist and lecturer at the Yale University School of Medicine. She examines mental health policy as well as political trends in medicine. So I cannot even imagine how all of that looks and how busy that would keep you, but I am thrilled to have her. Sally was recommended to me by a friend, our mutual friend, Gil Kurlikowski. So Gil, if you're listening, thank you for bringing me together with Sally. So welcome, Sally, psychiatrist, practicing clinician, medical doctor. You're really front lines of this opioid epidemic, and I would love to hear your thoughts. Let's start with, how you viewed the political response, if we may, to what we were witnessing in the 2000s, early 2000s, and did politicians and policymakers get it right, and did they get it right in a timely manner?
Wow. Well, early on, there was, I think the first article that I saw on, I think it was dubbed Hillbilly Heroin, but, the spread of OxyContin was in maybe 1999. They do remember in 2001, the New York Times Magazine had a big article. It was really well done by Paul Tough. And it was, I think it was called The Alchemy of OxyContin. And alchemy is a perfect word for anything you're talking about when it comes to addiction, because it's such a multifaceted problem. As far as a federal response back in the 2000s, I don't recall there being really that much of it. I really recall the national focus on the drug problem, and it was really the tail end of the pill problem by around 2015, 2016, was actually during the presidential cycle of 2016 with actually Donald Trump. And there was such an effort to understand him and the people who found him appealing, forgetting that a lot of upper middle class white people did as well. But, there's a lot of focus on the rural population and his populist tendencies, and the places that voted for him also had the highest overdose death rates from opioids. And that all came together as an understanding. Also, deaths, the whole concept of deaths of despair, that hit in 2015. It really was a perfect storm. And then J.D. Vance's book. So all these things came together, and there was an image, and a very sympathetic one. Rural white folks kind of left behind, often in areas that had become hit by industrialization, either because a big industry just moved out overnight, or in the case of Appalachia, where I actually spent a year, 2018 to 2019, a small town in southeastern Ohio, where the industry just gradually leached out. So it was more of a slow motion decline. But that's when it really started to get a lot of attention. And President Bush commissioned a commission with Bertha Madras, who I know you had on the show, to respond to the crisis. I think they had 117 recommendations. It was a lot. I exaggerate, but it was a lot. And that's my recollection of when it really started to get national attention. Then that changed a little bit. Not that Congress's attention is still on it, funding much more treatment than ever before. And right now, looking into the fentanyl, the border issue and interdiction on fentanyl as hard as they can, which is hard. But also around 2018, 2019, a lot of the documents from the Purdue trial were made public. And then, again, this is impressionistic, but it was my sense that there was a little less focus on who's getting addicted and why, and more on the depredations of the pharmaceutical company.
Well, Sally, can I interrupt here? Because I think, by the way, your TED Talk is fabulous. Anybody wants to look at Dr. Satel's TED Talk on this topic, I highly encourage it. Obviously, Google it. It's about 22 minutes long. But I think this leads right into what you talk about so well in your talk. And I'm not trying to recreate your TED Talk, but it's brilliant. If I could, I would, because it's that good. But I think the notion, the translation from academia, from your thoughts and your thinking into the political realm, smack dab square in the divide there might be what you call the comforting fictions. And because we buy into them as policymakers, we buy into them as parents. And I would love to hear you talk a little bit about the comforting fictions. I am embarrassed to say that I've never heard this before. And when I listened to you talk, I went, this is what's been missing. So what are your comforting fictions?
Thank you. I'll tell you one of the comforting fictions, and then I can get into all of them, but I'll use this as an entry point, and this may sort of shock some folks, but is that one of the comforting fictions is that the opioid medications, which are excellent if you need them, did we overprescribe? Yes, doctors overprescribed. Did Purdue misrepresent their product? Yes, all that is true. I stipulate everything. But the average person can use, oxycodone, and that often comes as Percocet, or hydrocodone, and that'll often come as Vicodin, without any problem at all. 60 to 90% of people prescribed these drugs have them left over in their medicine chest. Are they stolen by your teenager's brat cousin? Yes, but and that also, someone said this to me, it seemed like a killer comment. If these drugs were so universally and ravenously addictive, how did anyone have any left over in their medicine chests? So the reason why that's important is because that exaggeration of their massive addictiveness, the power of these drugs, and yes, are they powerful for people who are vulnerable? Indeed, those are people who have a history of addiction or a concurrent psychiatric problem, or even I would say just an existential, they're in just great distress at the time they are prescribed these pills. Those are folks who do have, there's no question, they have a 3 to 4-fold higher chance of becoming addicted. But they're still not the average person. And doctors need to be aware of that vulnerability, there's no question. But because, again, their addictiveness was exaggerated, I think it's no coincidence that was very helpful to the trial lawyers, that the policy of curtailing prescribing was applied with a machete and not a scalpel. And so many people now, especially people with chronic pain, are being denied the medications that help them get out of bed at the least and help them go to a job and be with their families and enjoy activities with them at the most. Is, if I sound a little histrionic, forgive me, but it's truly a human rights problem that we have so many people who are suffering profoundly from untreated or undertreated pain. And in fact, a colleague of mine is keeping a registry. He applied for a grant. He's trying to do this in as formal way as possible, of people who've killed themselves because they couldn't get the medication. So that is one comforting fiction, that it's the drug and it's not the person. And what I mean to say is I think we focus way too much on the power of the drug, and they are, sure, heroin, cocaine, OxyContin, they are more powerful than aspirin. There's no question about that. I wouldn't deny that for a nanosecond, but we put too much emphasis on the power of these drugs and not enough on the vulnerability of the people who are using them.
I agree with you. I'm a believer that there's a time and a place for opioids. I had an epiphany. I broke my arm snowboarding, and trust me, I was in a board meeting for a nonprofit that focuses in this space, and my tendon snapped at that time. It's like, I need opioids. So I understand that. I completely do. But isn't just being a kid a vulnerability? Isn't letting these pills fall into the hands of being diverted out of that medicine chest into the hands of a 13 or 14-year-old or a 12-year-old who's getting it on Snapchat? Isn't that a vulnerability in itself?
Oh, well,
just being young?
Yes, but not just being young with a sense of, it's one thing to experiment, and certainly 13 is way too young to experiment. There's no question about that. But, and people talk about a younger brain being more receptive or amenable to the process of, that the reward pathways may be. I'll just use those words crudely because I'm not a neuroscientist. And I believe that a little neuroscience is a dangerous thing. So I leave it to the true professionals, even though I am a psychiatrist. But yes, there's no question that a teenage brain is more susceptible to let's just say the chemistry of addictive drugs. But where the teen brain really becomes a vulnerability is in the context of a group of other teens. They're much more prone to peer pressure than adults, and if everyone else is doing it, that's also compelling to them. But there's a difference between using these drugs and becoming addicted to them. Clearly, if you don't use them, you'll never be addicted. So that is an entry point. But if you're living in a situation, if you're living in a home that's challenged, if you're not doing well in school, if you're living in a neighborhood where it's just the school isn't that good, and the economics of the place are embattled, and family structures have frayed, and church attendance is going down. These are all external contextual situations that make that kid much more vulnerable to continuing to use, and to the point where it becomes addictive use as opposed to just pleasurable use, that kind of thing. So yes, I certainly agree completely, and maybe that's a segue into another fiction that comforting fiction, which is that addiction. I've been a critic of this forever, I have to admit. Frankly, since 1997, going on 30 years, I've been a critic of the formulation that addiction is a brain disease. I know it's very popular, and as we were talking about earlier, as a clinician, if a patient told me that that's how they prefer to understand their problem and it helps them to understand it that way, I would never discourage them. But what I do ask of people who want to call it a brain disease, which implies involuntariness, which implies the problem is in the brain and not in the mind, that they understand what kind of disease it is. And addiction is a kind of disease that responds to consequences. That's how people come into treatment. Their wife is going to leave them. Their probation officer is going to fire them. Their boss is going to fire them. The probation officer is going to violate them. Their kids hate them now because they haven't been to any of their games. If you had a brain tumor, none of those reactions would make a difference at all, because addiction is not a biologically autonomous process like, let's say, a brain tumor is. So addiction is a kind of disease, if you want to think of it that way, that responds to reasons and consequences. Those are both together there, reasons and consequences. And that, to consequences, 2 out of 3, it's a disease that people engage in or begin for reasons. People have reasons that they use drugs. They help them early in their career use, before it got out of control, before their life they've created so many problems for themselves and their family. It worked. It worked for their anxiety. It worked for their self-loathing. It worked for their boredom. It worked for their feeling that there was no boundary between their self and the world. It worked. And that gets to the third thing that you have to understand, if you want to call it a disease, and why it's different from most other diseases, is because people are very ambivalent about giving it up. That's why I'll stipulate both. In some places we don't have enough drug treatment, but even when we have enough, people are not rushing. The take-up rate is much lower than you would imagine. And once people are in treatment, the dropout rate is massive. It's up to 50% within the first 6 months. Why would that be? If you're even if you're in a good treatment program, I know some of them could be a lot better, but when you're in a good treatment program, when you're on methadone, for heaven's sakes, you've heard the phrase dope sick, and it's a true phrase. It is true when people, that's withdrawal, feeling withdrawal coming on. And that's been used by some to say that is why people continue to use drugs. That's what perpetuates their addiction. And I will grant that, of course, if a person is using a classic drug, whether it's withdrawal, alcohol, opioids, barbiturates, benzodiazepines, that yes, the beginning of that sensation of withdrawal does prompt someone to go out and buy more. So in the short term, there's truth to that. But you have to see in the long term that it's a very hollow explanation. If you think about people coming into a methadone clinic, right? You come into a methadone clinic, within a day, your craving is suppressed, your withdrawal is suppressed, because that's what methadone does. Maybe it takes 2 weeks to get the dose right, sometimes a month. And that's what I do. I adjust the dose for folks. Well, now they're not craving. Now they're not, or they're at least not, they're experiencing the kind of craving that comes with withdrawal. They're certainly not having withdrawal symptoms. And yet they're still using drugs. Why is that? It's because it's not all about being dope sick. It's about these other things we just talked about. It's why people feel that they need to either numb themselves or change their inner state in some way to make their life more livable. So those were, I think, the main comforting fictions that I tried to undermine.
Well, you brought up a great point there, Sally, though, because there's been a lot, especially on the West Coast, attempts to arrest somebody, or rather than sending them to jail, we send them to treatment as if it's going to work. And maybe oftentimes it does, but
it usually doesn't.
Not.
But that's where drug courts come in. That is where a benign coercion. I'm all for benign coercion, because remember, what's the option? You could have been arrested instead. You could be in a jail cell. Isn't it better that you are, and you're offered, a lot of people just offered that choice. Would you like to go into a drug court, or should we proceed with the judicial process or the correctional process as normal? And some people don't want to be in a drug court. They don't want anybody telling them what to do. They just want to do their time. And these are people who've been in jail before, usually, But thank goodness a lot of people do opt for drug courts, and they work because they make very constructive use of what are called contingencies, that there are consequences that are immediate, swift, but not severe. And that's the key. It has to be immediate. That's how you train any organism with a spinal cord and a cortex, is you have to respond right away. The ultimate carrot is that your charges are expunged at the end, which is at least usually a year. And, these are pretty, they don't work brilliantly, but they're as good as or better than treatment that is voluntary. And that's another myth that is worth exposing, which is this idea that unless you want to be in treatment, it won't work. Treatment that is coerced, will work as well again, or perhaps better. And it's because over time, and we're not talking about a week, we are talking about a year. But over time, the person in that program, well, first you just physically feel better. Because, your brain's a little clearer, you're not in withdrawal. Hopefully they medicate people, through the withdrawal period, or send them to a detox. Then they start to feel better. That's encouraging. Their family sees maybe there's some hope, so they start re-engaging. They see people around them who are farther along in the program, and they think, well, he was as bad as I was, 3 months ago, but look at him now, he's in a job program. And so people do get hopeful. And that's how it works. That's why coerced treatment can work.
I'd like to take this time to thank my incredible sponsors. Lucy Pet Foods is the leader in gut health. Their formulas for life feature prebiotic balanced fiber that nourishes your dog and cat's total health. Every purchase helps support the Lucy Pet Foundation, a 501c3 charity helping animals. Save 15% off your first order. Use the promo code SAGELYSPEAKING, all one word, and you'll also get free shipping at lucypetfoods.com. And the code word to enter to win our gift box is Lucy. If you're committed to tackling the opioid and addiction crisis, then you need to be at the 2025 RX Summit. Join top experts and professionals as we share strategies for prevention, deflection, treatment, and recovery. Don't miss this chance to be part of the change. Head over to rx-summit.com to register now. Use code SAGELY, that's SAGELY, for an extra $100 off. That's rx-summit.com for an additional $100 off. Mothers Against Prescription Drug Abuse. driving solutions to prevent drug abuse and overdose deaths by focusing on prevention through education and awareness. All of our sponsors can be found on our website at sagelyspeaking.com. And now, back to our interview. You are popping some of the myths or bubbles that I've bought into and talked about for years. The other one is reducing stigma. And of course, there's a lot to unpack there with what does it mean to reduce stigma. But and our mutual friend, Dr. Keith Humphreys, also is big on this. And I enjoy it because, again, it's not a black and white issue. And I think, again, in your TED Talk, you do a great job of talking about stigma. And I think this is important and instructive for advocates and policymakers to hear what you have to say about stigma. Can you share a little bit about that?
Sure. I have two general comments. One is that folks seem to think, and this is what the National Institute on Drug Abuse thought, and intuitively it makes sense that if you describe a condition, a behavioral condition, as a brain disease, and that's a level of reification that's way above just disease. If you talk about it as a brain disease, then you will reduce stigma because clearly, no one blames someone for having cancer. And I've heard people at night make that analogy. And then we'll have more money for treatment, more research money. We will move this problem out of the criminal justice system, which is certainly a direction I endorse. But it turns out, and there's now just a huge collection of research on this, showing that when you describe a behavior in terms of genetics or in terms of biology, in terms of neurobiology especially, that actually makes people more fearful of the person with that behavioral problem. They may ascribe a little less moral agency to them, but they'll be more afraid and they will have less confidence that treatment works. So there's a therapeutic nihilism that comes with that. So that is not as helpful as some of the promoters of the brain disease as an anti-stigma vehicle worked. The second thing is that, shame is completely natural. As a clinician, God forbid, you would never, it's out of the question that a treatment system would ever contribute to someone's feeling of shame. And I think in ERs, I've worked in ERs and they're tough. And, you don't feel so great when you walk in as an addict. You don't feel great when you walk in as anyone, but they can be pretty brutal when you're an addict. You get the sense that you are quickly. So that's not acceptable. But the truth is, and again, good data on this, that shame is an excellent motivator to try to change one's circumstances. And it can be constructive under conditions where people feel that they may know how to or can get help with changing that circumstance. If they feel it's hopeless, then they may use drugs even more to medicate the distress of that hopelessness. But if they see a way out, that can actually work very well with a posture of shame to help people recover.
If I can take that, though, 1 degree aside, shame extends to the family, and the family is generally powerless and helpless over changing somebody's addiction. Mm-hmm. And that shame creates a lot of walking wounded, or I guess, collateral damage. And how does a family, and I don't know if you treat families too, especially, certainly not in your clinics, but how does the family reconcile, gee, you have an addicted, child, or, your husband is addicted, or, that shame that follows onto people who live with, whether it's a disease or not, living with addiction. Yes, I think you get what I'm saying here.
And I wish I could. I don't work with families, and that's an excellent question. My general, and you really must have someone who does. I'll just say that whenever, I think one of many, but one approach is to, first, just make sure they understand what's going on. I think a lot of families probably engage in some endorse some myths as well. Well, I would also certainly encourage, fellowship type, AA or other kinds of groups. I think that would be hugely important to understand how other families did it. And to, I'm sure even families, even moms and dads who had the best upbringing, the best schools, the best this, and not just the best this because they're rich, but also the most love, will have a kid who just, who knows why, really. Some young people are just born with some of those traits we discussed earlier, an intense feeling of just inner discomfort that's just so hard to dispel. And then they take that first drink and, oh my God, this is how normal people feel. You can't control that as a parent, but even the best parents, I'm putting air quotes around that, wonder and torture themselves over what they have done wrong. And that's something they may want to go into therapy for, to try to tease apart, not to blame themselves if there was things they did. Who knows even what you do wrong, because you did it wrong with the older kid and he's fine. So I realize I'm not giving you a straight answer here, except it's really hard.
Well, I'm realizing I'm putting you on the spot for things that are your wheelhouse, just next to your wheelhouse. But, I just was kind of just to say that stigma is interesting.
No,
because
it is. It's like vicarious stigma.
Understand. Right. And I understand completely with what you're saying about the person with the addiction, and then as opposed to, but, to some degree, do not stigmatize people who love somebody because it's hard enough, I think. So this is the way I view you, as somebody who can unpack facts here, and put together a story that just makes a lot more sense on all of these issues. And again, the brain disease, and I have said that, and I'm viewing it differently now when you talk about the comparison between addiction and you alluded to it a little bit earlier, but addiction and, say, Alzheimer's.
Yeah.
And the choice, the point that there is a choice with addiction, and whereas with Alzheimer's, there's not, your carrot and stick kind of analogy that you use. So just in that, you've made me view things a little bit. You're going to make me think for a while, Sally.
Well, that's a great compliment. Thank you.
Well, I wish we had more of that in this world right now.
Well, a lot of reaction, a little less thinking. I don't know if we're almost done, but can I make one last comment?
Please. Absolutely.
Okay. Well, I've been accused. I mean, what else is new? Everyone's accused of something these days, but I mean, of being insensitive. With this reformulation. Like I always say that, and my late brilliant colleague Scott Lilienfeld helped me think this way, that there's no definition of addiction. There's no real definition. I would say it's a behavior. I actually say it's a symptom. I think addiction is a symptom and not a disease, because it's an effort to, again, address distressing, highly, deeply distressing states. Sometimes they're kind of from within the person, in a sense. I've just never felt right. I have to blot out traumatic memories. Again, this whole litany of reasons. Self-loathing, when you read addiction memoirs, is a huge one. Sometimes people live in environments where if they were been able to be taken out, or if the factory came back 6 months later and all the men who started drinking would stop. So sometimes it's more of an environmental thing, but it's still a symptom. I think that's much more constructive way to think about it, as a symptom than a disease. And with respect to Scott and his formulation, which I like a lot, is that addiction is a phenomenon that expresses itself and plays out on many different levels simultaneously. And one is the brain. Of course it's the brain. Why would people use drugs if it didn't change their brains in ways that they found rewarding? And craving is very intense. I'm not trying to minimize that. Even people who want to quit just feel they can't fight their craving. But that's one level. There's the neurobiological level. Then there's sort of the behavioral level, and that's more the Pavlovian dynamic, where you run into you're bombarded by cues that remind you of your use, internal and external cues, people, places, things, and sometimes emotional states, and then you're craving, and you have to learn how to deal with that craving. So there's that level. Then there's the psychological level, which is where the addiction memoirs come in. And then there's the, environmental level, is what's going on around you. Is it normalized? What's the culture? And these are all valid. They all are in operation at the same time. But if you're a policymaker or a clinician, the brain, that first level of neurobiology, is the last place you want to look. That's the least helpful. If you want to say something like, well, what about methadone? What about buprenorphine? What about, well, those are the best we have. We have some drugs for alcohol, medications for alcoholism too. Great, I use them. I'm not against them at all. There's not been one new anti-addiction medication since the 80s. Not one. And methadone, as you know, goes back to actually World War II, but it was used as a painkiller then in Germany. That's where they created it. And it was first used for clinical purposes in the very early 60s. Buprenorphine's been around for a long time. Narcan's is not a treatment, but the antidote, Narcan's been around for decades. None of this is new. We're not making any new progress, really, in that regard.
This is huge, but it's also, is this not hugely important on the pain front too? Pain management, opioids are so cheap and so easy. And are we doing enough to invest in new, novel approaches, novel pain therapies that are non-addicting? And I understand your point. Not everybody who takes them gets addicted. And so we're not doing enough and to innovate and in these spaces for sure.
I know that it is, again, this is not my area of expertise and drug development, but I do believe that there really is an effort, and it's been going on for almost a century to find a pain reliever that's not addictive. But the other problem, that's something you could fix sort of overnight, and but it won't because it's so political, which is just better integrated pain treatment. Opioids are not, forget they're cheap, they're the only thing some doctors have because their patients don't have insurance that covers really integrated, pain management, which can be really helpful. But then these poor folks are on, opioids for a long time, maybe if earlier, once they were injured or developed their chronic pain, they could have avoided it or been on lower doses. That's all very possible. But the point is now, this is what works, and we're ripping people off it. I'm actually an expert witness in a case. I don't believe it's settled, so I think at some point I could actually talk about it, of a man who was on roaring doses of opioids, very high, well over 1,000 morphine milligram equivalents in the form of fentanyl as a patch and fentanyl as a, the lollipop, the Actique, which is more for breakthrough cancer pain. That's what it's been FDA approved for, but it can also work for breakthrough, any kind of, or at least in his case, musculoskeletal pain. I'll fast forward and say his doctor got scared that about the DEA, and they do come down. Some doctors deserve to be rated, but a lot don't, and they're really putting a lot of pressure on doctors who are doing their best with very difficult patients. They're the only doctors who will treat these folks, so they get the most difficult people, and on the highest doses. This man was a brilliant patient, never failed a urine test, always could present, his pill count, that kind of thing, and he killed himself because his doctors tapered him off. He committed suicide. He shot himself in his house with his wife. His wife was in another room. I know it's hard for doctors. They really feel they are caught in a hard place with the DEA, but they have that's a whole nother issue. There's got to be more, and used this word before, much more nuance in approaching these issues. It's not black and white. These drugs help people. Not all doctors who prescribe high doses are irresponsible. In fact, some of them are the bravest people out there now.
Well, Sally, this brings us sort of back to the beginning. And as we wrap up, let me go back to the beginning. That's always a great thing to do, right? The policy response. And when things get ignored for too long, neglected, your constituents, in my case, we were losing, I run a nonprofit that was started by 3 moms who each lost a child to accidental opioid overdose. And they weren't being heard. And so you begin to get this emotion. Look, it's the nature of politics, especially these days, right? The nature of emotion comes up. And so then you put pressure on the agencies, whether it's DEA, DOJ, let's go down the list. And you start ramping up the pressure. And there's so much pressure because the crisis is escalating that there's no time for thought. And that's why I think conversations like this are so important and critical to continue to have, to really unpack, so the pendulum doesn't swing too far. And I'm a part of a group called the Collaborative for Effective Prescription Opioid Policies, CPOP we call it, and that's our goal, is to have these conversations, to continue to lead, and how do we keep opioids out of the hands of a 12-year-old who's getting a Snapchat, but then how do we allow this man or woman who's in severe pain to live a life to the best of their ability and be treated by a doctor who's not fearful of prosecution if he's doing the best and most ethical job he can do. So that's why I love your conversation and your TED Talk And I know your TED Talk is just a tiny little opening into your brilliant thinking. And I hope that we can continue to work together and talk more and work with the advocates so that the advocacy isn't the pendulum swinging so far that we miss the sweet spot in policy. So I want to thank you. And after my big diatribe there, you have anything you want to add?
No, thank you for the kind words. And yes, the pendulum, especially in the pain. First we were afraid of prescribing, then we got too aggressive about it. Now we swung back. And just on that particular note, that's a brilliant example of it. And yes, more nuance in thinking about addiction, because it would lead to better policy.
And that's what we're all about. So I want to thank you very
so
much. I do hope we work together. And I, again, thank you for being here with Sagely Speaking. I want to thank my listeners. I know a lot of you care a lot about this particular topic, and a lot of you aren't as interested in it. Either camp you're in, just thank you for listening to Sagely Speaking. I want to thank my sponsors very much. And until we meet again, be well.
Thank you.